Thank you very much for inviting me here to a beautiful day in Berlin. I was very pleased when Klaus originally asked me to speak at the conference. Firstly, for the opportunity to return to Berlin. Secondly, for the opportunity to talk on what is rather a pet project for me, as some of you will know, and over the next half an hour the rest of you will certainly know. And finally, I was very pleased to come to a School of Governance and to see that public health and health inequalities are being studied within Germany from a public policy and political science perspective, something with which I have great sympathy. So today I want to talk about a series of pieces of work which I've been involved in and which draws on the work of other key researchers across Europe, in Spain, the Netherlands and so forth, which takes the welfare state regimes concept from comparative social policy and political science and puts it firmly within the public health realm and how to analyse health inequalities and overall population health using this concept. As you can see, I'm based at the University of Durham, which is in the north of England, and I'm located currently in a geography department, and my concession here to geography is to have a nice map on the front page for you, illustrating the welfare state regimes. There are four things which I will be covering in my talk. Firstly, I'm going to give a brief overview of welfare state regimes, the concept, the debate that came about after Espen Andersen published his 3 Worlds of Welfare, particularly the debate within the social policy literature over the past 20 years. I'm then going to talk about how this work, the concept, has been applied to overall population health, so public health in general terms. I'll then start talking about more recent work in which I've been involved applying the concept to health inequalities. And this work came particularly from the Tackling Health Inequalities project, the Eurothine project, hosted by the University of Rotterdam, Johan Mackenbach, Vicente Navarro, and so on. Finally, as you will see from my title, this idea of a puzzle, I will draw upon theories of health inequalities in the broader literature to try and explain some of the issues which I think the health inequalities and welfare state regimes literature has given rise to. So, together I hope we'll explore what I see as a public health puzzle. So, we have the concept of welfare state regimes from social policy, and I'll go into more detail later. But generally, as a lot of you have discussed in the workshops, and as was alluded to in the discussions this morning, there are 3 to 5 different regime types. The key name in this area, of course, is Espen Andersen. When these concepts have been applied to population health, studies have invariably concluded that the social democratic, the Scandinavian or the Nordic countries have generally had the best health outcomes, particularly when contrasted to the liberal regimes, countries particularly UK, Ireland, as we heard earlier, the USA. With the more recent studies, though, that have taken this welfare state regimes concept and applied it to health inequalities, as Klaus mentioned this morning, we've begun to see that actually the cross-national differences in health inequalities do not match up to the cross-national differences in overall public health. To put it simply, the expectation in the literature is generally that the social democratic welfare states, given their high levels of income redistribution, high levels of decommodification and so forth, the expectation is that they would have the smallest socioeconomic health inequalities. However, as was originally stated by Espen Dahl and colleagues in a book chapter in 2006, this is not the case. The more recent Eurothine work has discovered that in fact it's actually the conservative continental countries such as Germany and France which seem to have the smallest inequalities in health. As you'll see in my talk, this challenges a lot of our existing theories about what causes health inequalities. And so I'm going to talk through this with a focus on those explanations and what this means in terms of theory development and also in terms of what we can do about tackling inequalities in public health. Now, as you can see, I've just put up here some of the typologies that are popularly used in public health research. Of course, I think everyone's most familiar with Espen Andersen's threefold, the 3 Worlds of Welfare typology, which Espen outlined earlier this morning. However, There has been a significant debate since Espen Andersen published his work in 1990, a particular debate around the methods that he used to construct the typology, the fact that it focused on male workers and had very little on women and the family, the fact that the principles behind it were very much focused on income maintenance schemes rather than looking at other aspects of welfare state such as healthcare services. There are also debates about where particular countries should fit. For example, the positioning of Japan or Italy. And also discussions about the number of different regimes, whether there should be a fourth radical regime, whether there should be a southern regime, and so on. I did a review of the literature a few years ago and discovered that there were about a dozen or so different typologies, as well as about 6 or 7 taxonomies. So, for example, typologies created using cluster analysis. So this was quite a productive field of knowledge in the mid to late 1990s. Of course, it's difficult to cut through all of that, and I think in public health research, as the concepts have been taken from social policy, there's been a tendency to focus, perhaps naturally, upon Espen Andersen's work. But more recently, certainly in the work that I've done with colleagues, we've looked particularly at Ferreira's typology. We did an analysis showing that this was the most accurate in terms of how welfare states spend their money, how they generate the money. So this is something that's quite prominent now in public health welfare state analysis. And secondly, because of the prominent role of Navarro and colleagues within the welfare states and health debate, their political typology is also used quite a lot within public health studies. The key thing for both of these two new typologies is the addition of the fourth regime, called the southern or the late democracy, depending on which typology. Of course, what you can also see in this table is that there are differences between the composition. Here, for example, the Scandinavian regime is far more condensed within Ferreira's typology than the equivalent ones in the other two typologies. So this is something that we might come back to later. In terms of the southern regime or late democratic regime, generally the welfare provision here is seen as less centralised, more fragmented, high reliance on the family and the voluntary sector, and different levels of compensation across different programmes. So, how has the welfare state regime's concept been taken into public health? Well, most of the studies which have looked at overall population health have tended to focus on indicators such as infant mortality rates or closely related indicators such as the low birth weight of babies. In fact, only one study has actually looked at morbidity, self-reported health in this case, from a welfare state regime's perspective. And as I mentioned in my introduction, these studies have consistently shown that infant mortality rates, IMR, vary significantly by welfare regime type, lowest in the social democratic and highest in the liberal and southern countries. I'll just briefly talk you through some of the key studies here. As you can see, they're all fairly recent. So the first was the Connolly and Springer. They looked at infant mortality rates over a sort of a 30-year period, and they found significant differences between the three regimes, so they used Espen Andersen's typology. Similarly, in a more recent publication, Coburn found that Scandinavian welfare states had lower IMR, lower overall mortality rates, and less mortality at the younger ages. In a paper which I did, I also found similar results, but also a moderate correlation between decommodification levels and infant mortality rates, suggesting that labour market decommodification provided by different welfare state regimes could be an important link, an important mediating factor in the relationship between GDP per capita and health outcomes. Similarly, Navarro and colleagues, using their political regimes typology, found that the Scandinavian countries, the social democratic countries, had lower IMR, although it was not quite as consistent in terms of increased life expectancy at birth. And I think one of the things to take away is also that there are very few studies looking at overall adult health outcomes at in terms of overall population health. This is generally because the regime's concept doesn't particularly work when applied to adult health indicators as opposed to infant mortality rates. Infant mortality rates, though, of course, are seen as particularly sensitive and useful when doing cross-national comparisons. Chung and Montaner multi-level modelling found that around 20% of the difference in IMR and about 10% in low birth weight could be explained by the type of welfare state. And again, the social democratic countries performed significantly better than the other regime types. Taking a slightly different perspective, Lundberg and colleagues, Espen Dahl mentioned this study earlier, looked particularly at policies that are associated with particular welfare state regimes. So, for example, policies supporting dual earner families, which are associated most strongly with the Scandinavian Nordic countries, or looking at generosity in terms of basic pensions. And they found that when welfare states used policies that were supportive of dual owner families, there were decreases in IMR, but spending the same amount of money on policies to support traditional families, as tends to happen within the southern or the conservative countries, were not so successful and had no effect in terms of health. And again, a similar pattern was found in looking at older age mortality and the nature of pension provision. In a study in which I was involved with my colleague Terje Ikemo, we found that after controlling for individual and regional characteristics, around 10% of cross-national differences in self-reported health, so this was using data from the European Social Survey, looking at self-reported health. Again, we found that 10% could be attributed to welfare state regime type, and again, consistently we found that the Scandinavian regime fared the best in this respect. I have to say that 90% of the differences were due to individual socioeconomic and demographic variables. So we can see that we have a clear case of social democratic supremacy. The Scandinavian welfare states, when we look at overall indicators of health, particularly in terms of infant mortality rates, are clearly leading in terms of particularly European welfare states. As has been discussed in a number of the workshops, this is partly due to the universalism, the generous replacement rates, high levels of decommodification, and extensive welfare services. And as Wilkinson and Pickett have shown in their work, narrower income inequalities as a result of these measures have resulted in better population health. This comes on to the second part of my talk, and I think the bit where the debate is perhaps currently at, and certainly where I think this conference has positioned itself, is to look at in terms of what does this mean when we apply the welfare state regime's concept to health inequalities. Now certainly, following from the literature that I've just overviewed, the expectation based on that, based on our understandings of health inequalities, and based on the macro level work of people like Wilkinson and Pickett and so on, is that health inequalities would also be smaller in the social democratic Scandinavian regimes. However, as colleagues have talked about earlier this morning, this is not the case, and I'm going to talk through some of those studies which have highlighted the fact that the health inequalities are not smaller in the Scandinavian countries, and that in fact they are actually smaller within the Christian democratic countries. But first I just want to note here, I've highlighted 4 of the key recent studies that came out of the Eurothine project. And I think it's worth looking for the later debate in terms of how inequality is measured. This can obviously be important in terms of what results you find. So here we have education, but measured in a different way in both studies, income inequalities, or a more kind of a coherent attempt at social class inequalities. The other issue is which typology is being used. So again, we have the two different typologies. The number of countries and, of course, the data sources also differ. However, that said, what we do find is a fairly consistent result, completely in contrast to expectations. As you can see in the table, I've ranked the countries in terms of the lowest differences between the top and the bottom groups. And as we can see here, Bismarckian, conservative, corporatist, I'm sorry, this language is perhaps confusing, but it's used fairly interchangeably. Anglo-Saxon, which would be the UK, for example, Scandinavian, so for example Sweden, Southern Spain, for example. So we can see that in the first study by Ickmo and colleagues, using education as the measure of inequality, the difference between the top and the bottom group was highest in the Southern regime and lowest in the conservative regime. And this we can see is consistent for men and for women. Karma-Burrell and colleagues also did a study looking at education. They used a different data source, and they again found that, the inequalities were highest in the late democracy, which is similar to the southern. But this study did find that the lowest inequalities, relative inequalities, were smallest in the social democratic countries. So far we have one in support of the hypothesis and one against. The Ickmo study using income as an example shows, again, the conservative countries have the smallest, but on this occasion it's the Anglo-Saxon which have the largest inequalities. The Scandinavians, though, are higher than the southern on this occasion. And finally, Esfeld et al. And colleagues have published in International Journal of Epidemiology. They found again that the Christian democratic countries had the smallest inequalities. And as you can see again, for these studies, the findings are consistent for men and for women. So, in summary of this body of work then, the expectation that health inequalities will be smaller in the more generous and egalitarian social democratic countries has not been shown, and in fact, as has been done, colleagues suggested, the picture is far more complicated, and I think this poses a big challenge to us in public health and also in terms of welfare state theories. We've found that self-reported health, that these various studies have found that the smallest inequalities are in the Bismarckian and that the largest tends to be in the Southern or the Liberal. And as I pointed out, only one study was in contradiction to this. So what does this mean? Returning to my idea of a public health puzzle, we can argue that the puzzle is actually twofold. Firstly, why are the social democratic countries not doing better in terms of health inequalities? And secondly, why is it that the Bismarckian ones seem to have the smallest health inequalities? And I want to talk about this by drawing upon the broader theories of health inequalities. And I will admit that this next section is somewhat speculative, but this is very much a challenge to us in public health. How can we explain this counterintuitive, counter-theoretical finding? And I'm going to explain it through reference to artifact, health selection, cultural and behavioural explanations of inequalities, the materialist explanations, psychosocial and life course. What do these competing theories of health inequalities offer us in terms of trying to solve the puzzle that's put before us? Now, for some of you are probably not from a health inequalities background, and so I will just talk briefly about what these different theories say about why there are health inequalities between different socioeconomic groups. So, drawing on the Black Report, a number of theories were suggested. The first one is the idea that it's artifact, that actually health inequalities don't really exist, it's just a result of how we've measured things. Now, in terms of health inequalities within a country, and I must stress this, the Black Report dismissed this as a reasonable explanation. However, within the wider health inequalities literature, there is a discussion as to whether the welfare state regime, the findings of these welfare state regime studies are accurate, or whether they are actually a matter of how things are measured. And I did try to point out in the table some of the different ways in which things were measured. Obviously, there were differences in findings between the studies, and you could argue there are differences in terms of which groups are compared, particularly in terms of the education studies. Does having a high education, say in Sweden, have the same value as having a high education in Spain? are we comparing similar groups within different countries? There are obviously other issues around the choice of typology. The different studies have used different typologies. So, for example, Karma Burrell's study used the Navarro-Shi, whereas Ikemo and colleagues used the Ferreira typology. This might be a factor of measurement that's explaining the controversial findings. There are also issues about which countries are included in the different regimes. As I pointed out in the first table with different typologies, different countries are located in different regimes depending on which typology you use. And I don't think we can ignore that that might be important. If Germany isn't included in the Bismarckian regime, we're quite likely to find different results than if it is included. And that may be why Burrell and colleagues' study has a different result from the others. Germany and the Netherlands were excluded from the conservative regime. More broadly, in the social policy literature, the idea of the welfare state regime's concept has been criticised, particularly by Kaza, who talked about the illusion of welfare state regimes. Welfare state regimes gives us the impression that particular types of welfare state are organised along similar principles, they have similar policies, and therefore they should have similar outcomes. However, this ignores the fact that there are lots of differences. I don't like the fact that the UK is lumped in with the USA. There's a big difference, as our speaker this morning explained. There are differences between Denmark and Sweden, as Espen Dahl illustrated with his labour market flexibility comments. Perhaps the welfare state regime's concept hides all of this, and that might be why we're getting these unusual results. There are also, of course, debates within public health about whether you can actually have accurate cross-country comparisons in terms of self-reported health, whether they're accurate in terms of socioeconomic status. And there's a debate about this between people, for example, such as Richard Mitchell or Bo Bergstrom. Although it has to be said that one study by Mackenbach and colleagues looked at mortality, and of course this had similar findings, so it's not just about self-reported health. I think perhaps more persuasively there's an argument made by Lundberg and colleagues from Stockholm, arguing that actually the welfare state regime's literature ends up being an attack on the social democratic welfare states, and attacks them actually for their success in terms of raising the health of the middle classes. This is an achievement, and it's not something that they should therefore be criticised for. And as Navarro himself has argued, the worst off in the social democratic countries are actually better off in absolute terms than the worst off in the other regimes. And there are clear political implications, I think, when we do show that the social democratic welfare states do not have narrower relative health inequalities. I think also from an artefact perspective, we have to say, I've obviously set this up as a puzzle, but is it actually a puzzle? Should we actually expect the determinants of health inequalities to be the same as the determinants of overall public health? So maybe I'm asking the wrong question. Moving on, another common explanation of health inequalities is the idea of health selection. So this is that health determines your socioeconomic status rather than the other way round. So, for example, people with ill health would be downwardly mobile, and that's why they become concentrated in the lower socioeconomic groups. The indirect selection thesis suggests that it's actually selection around the social determinants of health, for example, unemployment and so forth, rather than health itself, that results in this selection effect. As I've mentioned before, these are speculations about how to explain the finding. And so from a health selection perspective, is it possible that the social consequences of ill health are greater in the social democratic countries than they are in the others? Are people who have ill health more likely to end up concentrated in lower social groups? You have to argue instinctively this seems counterintuitive. It seems that it won't be the case. But it may be that through indirect selection, through, for example, higher rates of unemployment if you become ill, perhaps that's having an influence. There is, of course, strong protection in the majority of the social democratic welfare states to protect people once they get ill health, to protect them against unemployment and so on. Drawing on a study from the UK that I was involved in, looking at protection for people with a disability or a long-term illness, we actually found that this increased inequalities in unemployment. So it may be that actually protection can have an opposite effect. However, on the other hand, a study by Bo Bergstrom and colleagues found that the social consequences of ill health between Sweden and Britain, there was much less of a problem in Sweden than there was in Britain. So there is some debate perhaps around this. It does have to be noted, though, that selection tends to be more influential in respect to income-related inequalities, and obviously less so in terms of education-related inequalities. You tend to have your education much earlier than you develop ill health. So perhaps our health selection is unable to help us explain the findings. More prominent within the literature, particularly in terms of welfare states, is the cultural behavioural explanation. This is particularly associated with Mackenbach and colleagues. The cultural behaviour explanation says that the link between socioeconomic status and health is through the differences in health-related behaviours. These differences are a result of disadvantage, but it may also be that unhealthy behaviour may be more culturally acceptable amongst lower socioeconomic groups, something that we found out about in the workshop earlier with Patrick West's presentation. So what does this mean when we apply it to between country differences? Well, Mackenbach and colleagues have shown that perhaps it's inequalities in smoking behaviour that has led to the higher than expected inequalities in health in the social democratic countries. So, for example, they showed that differences in smoking between the most educated and least educated were higher in the social democratic countries than they were in the conservative countries. Indeed, in France, there's actually a negative and inverse relationship amongst women in terms of smoking. They also showed that this actually has results in terms of inequalities in cardiovascular disease, which again were higher in the social democratic countries as opposed to the conservative countries. Drawing on Espindar's paper, he suggested that perhaps universal health messages tend to be taken up by the middle classes first. So in the social democratic countries, everyone's gaining, but the middle classes do so at a quicker rate, and this leads to the persistence of inequalities. Why is this the case? Well, Max Mackenbach and colleagues have suggested the smoking epidemic is at a more mature stage within the social democratic countries, so they have very low rates of smoking amongst the middle classes. The materialist explanation of health inequalities, which was the one favoured generally in the Black Report, focuses on income and on what income enables. So particularly in a modern context, when we're talking about European welfare states, we're talking about access to goods and services and differences in the exposures to material risk factors. For example, the work environment and so on, as we heard in an earlier presentation. I think it has to be said that instinctively, the materialist argument is probably not going to be very helpful in terms of our explaining our findings. As we've heard, the social democratic countries have the smallest income inequalities. They offer largely universal welfare services, which are a right of citizenship. However, as Finn Diedrichsen has pointed out in the past, lower levels of income inequality do not negate inequalities in exposure to the other material determinants of health, for example, working conditions and so forth. And also from prominent research in the UK in the 1970s, when I was talking about a universal health service, Tudor Hart came up with the inverse care law. So where there's more need doesn't mean there's actually more access. Drawing on the work of Sturbu and colleagues, they've suggested and found evidence that there actually are inequalities in total avoidable mortality within the social democratic welfare state. So this is mortality that is amenable to medical intervention, so could be as a result of inequality in access, and that is higher in the social democratic countries than elsewhere. From a slightly different perspective, the social democratic welfare states have often been criticised in terms of running an insider-outsider approach, with new immigrants particularly excluded from the higher level welfare state benefits. So it may be that this is a factor behind the findings. One of the more prominent theories of health inequalities in recent years, particularly associated with Michael Marmot and Richard Wilkinson, is the psychosocial approach. And this focuses particularly on how social inequality makes people feel and the effects of these on biology and therefore on health. So the socioeconomic gradient is explained through the unequal distribution of psychosocial risk factors. What does this offer in terms of trying to explain welfare state regimes finding? Are there perhaps higher levels of social capital in the conservative countries? I think most literature suggests that actually it's very high in the social democratic countries, so perhaps this isn't helpful. One other angle on this is that relative deprivation might be a factor. This comes in any society in which there are inequalities, but particularly perhaps in the social democratic countries in which high expectations of social mobility are generated by high levels of education across the population. Of course, they are capitalist countries, there is a hierarchy, so there's a limit to how far people can go. So perhaps this limited social mobility has an impact on people's health and on the psychosocial stresses. This is, of course, highly speculative. I think an interesting perspective is one if we draw upon the life course. The life course, as we heard in the earlier workshop with some of our Finnish colleagues presenting, is that this approach combines other aspects of the other explanations, and key to this is that they allow different causal mechanisms and processes to explain the social gradient in different diseases. I think if we apply this across to our health inequality situation, it may be that we're seeing the same outcomes in our different welfare state regimes, the outcome being health inequalities, but it may be due to different causal mechanisms. We can't assume that because we have the same outcome, it's always the same processes in every country that's creating it. And I'd just like to draw on a piece of work by Margaret Whitehead and colleagues when they compared single mothers in Britain, which is an Anglo-Saxon country, with Sweden, a social democratic country. They found that in both of these contrasting welfare states, these women were more likely to report poor health than couple mothers. However, when they analysed the pathways leading to this, they found that in Britain it was poverty and unemployment that were the key issues, but that these were not factors in Sweden. So we have the same outcome, poor health for single mothers, but different causal pathways leading to it. So this leads me on to, again, one of Lundberg's comments, that perhaps the welfare state regimes approach that we're talking about today at the conference is actually only able to offer us a rough guide to inequalities. What we want, perhaps, is a more nuanced comparison of specific policies towards the unemployed, towards single parents, towards youth, and so on. And perhaps a life course perspective is pointing us in that direction. And this leads me on to my concluding comments, where I think this has been a long journey for me, but I feel perhaps now is the time to start thinking about moving beyond welfare state regimes. I think we have to think, is the puzzle that I've put forward, is it real, or is it a matter of artefact? I think moving beyond artefact becomes difficult. Our explanations are very speculative. I think there's some power within the cultural behavioural perspective, looking at smoking epidemic and so on. But more generally, our findings are clearly a challenge to conventional public health thinking, also comparative social policy thinking. Development is needed here, and we need to think more about how to explain these findings. I think it's possible that we need to start moving beyond social democratic exceptionalism. We might have to start thinking, actually, why have the conservative countries got the smaller inequalities? And what do these countries actually have in common? For example, fairly similar poverty rates. Alternatively, as Lundberg and colleagues have argued, perhaps comparative health should just simply move beyond welfare state regimes. We should ignore this finding, this controversial finding, and instead we should compare fewer countries on more precise policy areas. I think this is where the debate is at currently. What do welfare state regimes offer us? Are they the best way to analyse health between countries? And what do these findings actually mean for our understandings of health inequalities? And therefore, what policies are needed to tackle them? Thank you.